everyone. Welcome to our May webinar. Today we are discussing a very important topic. Just like every month we come back with a very important topic, but this is something that impacts every single person, every single individual in the world, every single country. And we have a very special guest speaker with us who's extremely experienced and who also comes with a very well-rounded knowledge of the topic. So we are really excited to have this discussion. Today, we're going to discuss, our topic is creating health equity, mobilizing grassroots action. And we all know how, all over the world, we don't have access to health services. And even in the health sector, we don't have health equity. And that's what we're going to discuss. We're going to understand from our guest what are the challenges, some of the things that we can do, and just learn from her experience. I'll just briefly introduce myself. I'm Lamona Chanda. I'm one of the co-founder of the Global Activist Network. We amplify voices that are creating impact on the Sustainable Development Goals. So welcome, everyone. And I'm just going to say a few words about our very special guest. Today we have Dr. Karabo Thokwane. Welcome, Dr. Karabo Thokwane. It's a huge privilege to have you here. I have heard you speak. I've discussed similar topics with you in the past, so I know how knowledgeable you are. But just for our viewers, I'm just going to say a few words about your background. So Dr. Karabo Thokwane is a public health strategist, executive medical leader, and global health advocate who's committed to advancing health equity through people-centered systems and grassroots action. With over 17 years of experience across clinical care, national policy, and health system leadership, she has played a pivotal role in transforming service delivery models in Botswana and beyond. Currently, she is serving as the Deputy Council Secretary of the Primary Health Care for the Mogoditshane-Thamaga District Council. Apologies if I'm pronouncing it wrong. Dr. Thokwane leads the design and implementation of integrated community-driven primary healthcare systems that bring services closer to the people. So it's a passion area of mine because where I come from, people don't have access to healthcare, and this is something that I personally find very inspiring. So welcome to our platform, Dr. Thokwane.
Thank you so much, Lamona. I'm very happy to be here.
Thank you. So we're not going to waste time. We're going to, dive into the questions that we have for you. Why don't we start by learning a little bit about your background and what inspired you to pursue this area of work?
Thank you, Lamona. The introduction that you did was quite comprehensive. I am the Deputy Council Secretary for Primary Health Care in Mogoditshane-Thamaga District Council. The country took a major reform in 2025 with the decision to rationalize primary health care or implementation of primary health care to the Ministry of Local Government and Traditional Affairs from the Ministry of Health. And with that movement, I moved from the Ministry of Health to the Ministry of Local Government. I think it was a great move, and I think I'm exactly where I'm supposed to be, because I do believe that primary health care is, like everyone knows, the tool for universal health coverage. But being where I am and having the opportunity to basically build the systems from the ground up, it gave me an opportunity to do something that I was of the opinion would work not only for the health system, but for our communities as well. So for the people, by the people. And what drives me is equity, ensuring that every single person has access to the same quality of care as anyone else within the communities that we serve. So my biggest thing is basically restoring dignity to my community, especially where I'm coming from, where the communities do have a reputation. We have the highest numbers of infectious diseases, of traumas, and so it's quite a complex district. So restoring that dignity to the community was something that really, really drove me. Thank you.
Amazing. It's one of the very few times I'm hearing you have created this connection between health, equity, and dignity, and this is something that we don't talk about a lot. Dr. Thokwane, you have experience of very different levels. Like you have leadership experience, you have worked at the grassroots level. In your view, what does health equity look like in practice within the community you serve? And how do grassroots efforts help define that vision?
So for me, equity means that it doesn't matter where you're born. It doesn't matter your socioeconomic status. It doesn't matter your gender. It doesn't matter whether you're disabled or handicapable, or your geographic location. You should be able to have access to, one, care, and two, the same quality of care that is available in what we would deem the elite. So in terms of the communities we serve, it means bringing the services closer to the people and integrating those services around the people that we serve, around their lived realities, and ensuring that communities are co-designers rather than recipients of health interventions. A lot of times we say that we are consulting, we are co-creating, but we call people or our communities to a workshop and we talk at them, and we don't give them the opportunity to actually share what their priorities are, what would work for them, and what they think we should be concentrating on. So grassroots efforts basically define for the people, by the people, because it's the communities that actually understand their barriers, and they would know why a clinic may be underutilized or why we should not build a clinic in a particular area, or why young people disengage from health services, or why certain interventions fail despite our good intentions. So they provide context, they provide legitimacy, and also they provide sustainability because they are the ones who came up with those solutions. So they have that buy-in. They created them.
Thank you. I have a follow-up question, which, I just randomly thought. I do appreciate that you feel that the process has to be democratic. Now, I mean, you and I, we both come from, and a lot of us, we come from regions that have been colonized in the past, and our heavy reliance is traditionally on Western medicine. When you interact with people from the grassroots, when you take their feedback, do you find that they have, because sometimes we can think that, no, we know better because we are the experts, but do you find that they have the knowledge that they're able to contribute that would sort of run a sustainable initiative?
Most definitely. And a lot of the times I believe that we need to, as technocrats, to empower our communities and to also give them that space to own their power. Because we might say it's your healthcare system, but then we do not give them the space to own the power. So, one, we'll ask them what they think when we know we've already made those decisions. So that empowerment means, one, we need to be decentralizing the decision making. And we need to be educating them, empowering them such that they're able to hold us accountable. We fund them such that they can actually come up with community-led initiatives. We build the local leadership capacity beyond. In our communities, we have the chiefs. We still have that traditional leadership, and we have the religious leadership, and we have political leadership, or what I like to think is more Western. So we need to be empowering our communities beyond that, and understanding that the lived-in experience actually comes as an expertise, because they'll be able to tell us what has worked previously and what has not worked previously. And also creating those accountability mechanisms where communities can influence priorities. In Botswana, we actually have the Khotla system, or the traditional system, where basically the people led by the chief are able to say what they feel. Traditionally, in that khotla, it is believed that everyone is entitled to their opinion, and that whatever it is that you are saying, whatever anyone is saying is wrong, basically. So I think leveraging on some of those things can really help us in empowering our communities. So we stop viewing our communities as beneficiaries, and we start viewing them as partners, and recognizing the power that they hold. Because honestly, without them, we actually have no power. So the power is with them, and we need to give them that space.
Absolutely. And this brings to my next question, which I think you have answered a bit already. How can local communities be empowered to lead health initiatives rather than being passive recipients of top-down programs?
Like you said, in a way, I think I did answer it, but like I said, we need to be walking the journey with them, and we need to be giving them that power. And we need to realize that where we are actually given the privilege to serve, because what we're doing is serving them. So the power is with them. We can do as many things as we like with the knowledge that we have, but without them, it's going to translate into nothing. So we need to be working very closely with them, recognizing their contribution, and also giving them enough space to do what they know would work for them. One of the things that I sometimes think about is even integrating our cultural practices and our religious practices, because the truth of the matter is our healthcare system is, I'm going to call it a tripartite. If I'm sick today, I'm either going to see my priest, or I'm going to see the traditional doctor, or I'm going to go to the conventional healthcare center, the GP.
Yes.
And those are the things that are basically integrated. And being able to recognize that those things are in existence and not think that they are lesser than what we think is the conventional medicine also gives us the opportunity to co-create and collaborate and even become closer to our communities. So I believe we just need to be closer to our communities and build that trust, because there's not much we can do without trust.
Thank you. I have a follow-up question, and this is coming from many years of observations I have had where I grew up. So on one hand, traditional practice of Western medicine or access to traditional healthcare is expensive for many demographics, for many marginalized communities. On the other hand, I've noticed that sometimes when they go to the priest or some local practitioners, there can be elements of what I would call malpractice, or, something like FGM. Female genital mutilation, these sort of things happen. So how do we manage those sort of situations? Like, how do we really create a balance where whenever people go, they actually get good health services?
I think we need to start by not separating ourselves from those practices. We actually need to be closer to them. I'll give you an example of one of the religious communities that we have in our country. They're called Bazezuru. So they don't believe in vaccinations. They basically don't believe in conventional Western medication or medicine. And my district actually has the highest population. So what we've done is one of the councillors, like one of the politicians, is a Mzezuru. So we requested him to arrange a meeting because sometimes having someone who's from the same community will actually open a door for you to start the conversation, rather than me coming with whatever thoughts that I'm having and thinking that they'll open up to me or they'll listen to what I have to say. And in our interactions, the idea was to actually listen and understand, but at the same time, where we're able to see commonalities or empower and say, but you know how when you keep on, I'm going to call it massaging, but we know that in medicine would say it's ECV, like it's external cardioversion. When you're doing that, it's part of the reason why sometimes the mummies bleed is because you're actually dislodging the placenta and it's causing a ruptured placenta. So we don't even need to give you medicine, but we can actually teach you the anatomy and the pathophysiology behind what it is that you are practicing. Right. So when we are able to come closer together and say, we understand, but this is what this means in this context. Would that make sense to you if we maybe not do it this way, or understanding that this cause harms this way, etc., etc. So I believe that sometimes there's always some form of commonality. Our traditional practices, there's a science to it, even though the science cannot be explained or was not explained in the olden days, but now we can explain it, and we can explain why certain things were being done the way they were being done. So if we're able to do that, then even the practices that are harmful, we're in a better position to say, you know, when a woman used to go into seclusion for 6 weeks and could not, these were the reasons. The same way, if this is why we should not be cutting the clitoris, for example. So it's finding a way of balancing some of these things and basically doing it in such a way that the people don't feel like you are being judgmental. Yes. And you understand where they're coming from. And also, honestly, we are taught that heritage is what remains the same, but culture is dynamic. So it should be changing, and it should be better, and it should be for the betterment of the community, of the people.
Absolutely, absolutely. Those are very, insightful things that you brought up. I think you have covered the next question that I was going to ask you, but if you have anything to add, please feel free to do so. I was going to ask you, what are the most effective ways to build trust in undeserved or historically marginalized communities when mobilizing grassroots health action?
Honestly, I think building trust, a lot of the times we interact with our communities when there's a problem. Our interaction with our communities is not consistent. Yes. It's during crisis or when they call us and they need an explanation on why certain things are happening the way they are. And at those times, we tend to be defensive, which does not help to build trust. So be consistently and starting, co-creating, building trust with the communities can go a long way in basically mobilizing our grassroots action, and not just going there because you want to tick a box, but actually listening and implementing and coming back and saying, this is what worked, this is what didn't work, why do you think this didn't work, how else do you think we can approach this? So ensuring that they know and they understand that you understand their lived in realities. It's not just about academics.
And we're not imposing only what we know.
Exactly.
Yes.
Exactly.
I think it will be helpful for us if you could sort of share an example of a grassroots movement that successfully influenced health outcomes or policy, and what, in your view, sort of made it work.
Botswana actually had one of the highest prevalences for HIV. And one, I believe it was because of our cultural practices. And two, Botswana is very strange. We are very cultural and we are also very religious as well. And of course, we cannot run away from westernization. So the westernized approaches were not really working for us. The modern medicine were not working for us. From a religious perspective, that was not working for us as well, because what we found when we were doing the studies was that the spread of HIV was mostly through sexual contact. But from a religious perspective, it's taboo to talk about sex.
Yes.
So engaging with the religious leadership went a long way, educating them and making it okay to actually talk about sex made it easier for them to actually now go and engage with our congregations while talking about sex and how sex was spreading HIV, because it's taboo. You know, people do things behind closed doors, and that was not helping. But if we call them out and we're able to say, we know that people, you know, they step outside marriages, so maybe we should be using condoms even when we're married. Or if you are going to be engaging in sexual relationships outside your marriage, ensure you're using a condom, etc., etc. That went a long way. Even in terms of our cultural practices, I'll give an example where if a woman's husband dies, they are expected to marry the brother as a cultural practice. But imagine now where maybe the reason why the husband died was from HIV. So this woman is infected. She's marrying the brother, who most likely is going to get infected as well. So getting the chiefs and the horses involved also went a long way in changing up some of these traditional practices. Even the myths, because there were even these myths that if you have sex with a virgin, you'll be cleaning your blood and you'll be cured from HIV. So getting all these groups that traditionally wouldn't be involved or actively involved in healthcare really did go a long way in changing some of the policies that we had in place, and also our community work, and even opening the door for us as practitioners to actually engage with the communities, because things that were deemed taboo became more open. We could put those things on the table. So I think that really helped.
Amazing. And you know, these things, when we look at the context, I think it adds more in intel, and we understand more how maybe, you know, I can lift this example and see how it might work in the South Asian context where I'm from. Amazing. So in your view, what role do community leaders, activists, and informal networks play in identifying and addressing health disparities?
A lot of the times, these are, I'm going to call them our early warning systems within the communities, because they will know what is happening before we even know. We look at numbers. They look at what is actually happening. It's their neighbors, it's their kids, it's their friends. So they would know what is happening before we're even able to figure out what is happening. And they would also understand the social dynamics. They will know what people believe and what could potentially be a barrier to care, and even just who is vulnerable in whatever situation that we might be working with. And honestly, because they are part of that community, we find that they are more trusted, because we are outsiders. And that's why I always think that it's always important to have community workers who are actually part of that community, because they are more trusted than someone who is coming from outside. So there's absolutely no way we can ignore the informal networks, because that would be missing out on a huge opportunity for mobilization, for prevention, for even movement building. So I see those people as actually our diplomats or our ambassadors. That's the word I was looking for. Our
Yeah.
ambassadors for health interventions.
And do you feel that there is enough research done on community initiatives so that other countries might divert their attention to these sort of initiatives more?
I think if there was more research, we would be seeing more being done, because when we look at just anecdotal data, tongue twister there, we are usually able to tell that community interventions do work, but because we don't study them and we don't see which part is actually working and which part did not work, we're not able to fully benefit from them. I've seen some studies, especially in India, because I think there's a lot that was done with primary health care, with community workers there, and with primary health care now coming to the forefront, more and more research is being done, but is it enough? It is not enough, and we need to be doing more. And like I said, I believe with primary healthcare really coming to the forefront, not just as a driver of universal health coverage and not just as a driver of health security, because it's also coming up as a driver of health security. I believe that we will see more data such that we're able to see what has actually worked and what hasn't worked.
Yes. Absolutely. How can then health systems better support and fund grassroots initiatives without co-opting or diluting their impact, in your view?
We need to start by giving up control. I tend to think that a lot of people who go into the health field, type A personality types, most of us. But the biggest thing is to learn how to support without being controlling. We need to reduce our bureaucratic processes, because these are not bureaucrats. These are normal, everyday people seeing issues and seeing what they think can work for them. Investing in our local leaders without necessarily making them technocrats. And allowing our communities to define what success looks for them or looks like for them. Building those partnerships with them. And funding is also very important, because we know that a lot of the times for us to be able to implement the things that we want to implement, we need to have funding. And sometimes in our quest to do good and to support our communities, we over-professionalize what the communities are trying to do. So we also need to be careful that we don't over-professionalize what the communities are trying to do. So our role would be to basically enable, we amplify, we support, and we also help those communities sustain the work that they're doing, not dominate it or absorb it. So we're there working beside them, not in front of them, but beside them.
Dr. Thokwane, I am a little bit emotional at the moment because, I was born in Bangladesh, and there's currently a measles, epidemic going on. So I think more than 400 children died, and it just, the numbers are adding. As an outsider, I do have minimal health background, but I'm not a health practitioner. I might sound quite negative, but I find we have been working on the primary health framework for decades. Why haven't we managed to reach areas where, rural areas? We're still struggling. We're still discussing. Do you share the same view as a health practitioner, or have you seen that we have made progress? When I look at some communities, at least some communities that I work with, there's no infrastructure. And I sometimes think, how can we even get these people under, health systems? It's that difficult. And I find it very difficult to understand, why haven't we made that developmental leap yet?
There has been developments, but the developments are very, very minimal.
Yeah.
And I believe the biggest thing is, a lot of the times we have a lot of very smart people thinking very smart things. We write very beautiful documents, but then translating those policy documents into actual tangible solutions and implementing those, I think that's something that a lot of countries struggle with. So for me, the biggest thing is, let's not wait for perfection. Let's start implementing.
Absolutely.
We will learn as we implement. We know that in some areas we have no, I think the question was, what is the biggest? Can you repeat that question?
I just wanted your
Apologies.
view on whether you think that we have made substantial development.
Some substantial.
Yeah.
Yes. So no, definitely, like I said, I wouldn't say substantial, but there has been some. But we just need to stop writing policy documents. We need to start implementing. And if we're going to be doing research, let it be implementation research. Let it be something where we are able to tell right now whether it's working or it's not working. We've been discussing, we've been talking, now it's time for action. And I believe it's through action that we can actually move primary health care forward, and we can bring those services closer to the people, and we can bridge that gap between communities.
Absolutely. So as a health leader, or as a leader in the health sector, what barriers do you think commonly prevent grassroots health movements from scaling, and how can those barriers be overcome?
The biggest thing is funding, because without funding, you can't do much, honestly. From your mobilization to your health promotion, even just transport, you need funding to get a lot of these things done. And sometimes you need to get a seat at the table. So if that particular grassroots movement is not recognized, it's going to be very difficult for them to actually get a seat at the table and to get that institutional recognition, such that when they speak, their voices are heard. And when you keep on trying and you are pushing, and very little is happening, you are going to get tired. And some of our community leaders do get burnout. Not being able to integrate some of the things that we are doing in our communities into formal systems will make it very, very difficult for them to be not only sustainable, but to also be able to scale up. And we are now in the technological era, and we cannot run away from that. And sometimes for people to hear you and for people to listen, you need to have data. And with data, you need technology, you need access. And a lot of these, our communities do not have. But one way, or one of the ways to really overcome those barriers, is by creating partnerships with the people in the formal health field. And these partnerships shouldn't be short term, they should be long term. Because if it's in the short term, we do what we are doing in our communities, and then we forget about it. But if it's a more longer term partnership, then it means we'll be able to strengthen our digital inclusion. We are going to have multiple projects. We are going to build succession planning or more leadership capacity. And we'll even integrate or engrave our community leaders into our governance structures, so giving them legitimacy. So scaling, we can do all these. Remember, we spoke about ensuring that our communities don't lose their voices earlier. So we can try to do that without our communities losing their authenticity, and also ensuring that we preserve that ownership that they have of the issues or the programs or the projects that they are implementing.
Slightly off topic. I wasn't going to ask you this, but I might as well ask you as we're discussing. Do you feel that artificial intelligence, which is the big topic in every room right now, this is going to help with promoting health equity at the grassroots? Or, how do you see it?
A lot of times we have a lot of tools that we can use. The tools are not the issue. The problem is with us. How we utilize those tools. I was talking to a colleague of mine. He just won a grant in teleradiology. And I was telling him, I think it would be great if you can come and implement that in my district. It's a tool that basically translates the radiological results into different languages. And I was telling him that, in my district, I have so many people speaking so many different languages because my district is quite diverse, complex. So I have everyone from all walks of life and I have the biggest population of non-citizens as well. So it actually uses AI to translate the teleradiology results into the language that the communities would be able to understand. So you see that we have this tool. I believe that we do not dissociate ourselves from the results. We actually still need to check if the results are correct. However, being able to translate that into a language that ordinarily I wouldn't be able to speak as a clinician would go a long way in building that leadership. Even just helping with how short we are on the ground. It means that I no longer need a translator next to me translating for this patient. This person can be somewhere else doing something that is benefiting another patient. So I believe that a lot of the times we do have tools, but it's how we use those tools. And I believe that AI will go a long way in helping us in patient care.
Absolutely.
And it will not replace clinicians, because you know what? It doesn't matter what computers say.
Yes.
They can never beat instinct. You know, in medicine, you know that these are the symptoms, but when something is still not adding up, AI will never be able to pick that something is not adding up.
Yes. Absolutely. And it's human intelligence, it's human interaction, also the warmth. There's so many things that, a machine can't do.
Exactly.
So my next question to you would be, how do you measure success in grassroots-driven health equity work, especially when outcomes may be long-term or non-traditional?
When we do our measures as clinicians, we always have our own KPIs. And I'm just going to segue a bit to say that one of the things that we are working on is a community scorecard. And in the community scorecard, it basically works like a normal balance scorecard, but it's basically measuring what the community would deem as success. And I kept on thinking, but we don't want it to look like our balanced scorecard and to be very disease driven and, maternal mortality, under 5 mortality, access, it needs to be talking to the community. What does it mean to the community themselves? For me, it would mean trust. Do the communities trust us? Cohesion. Do we see ourselves as one team, both the communities and the healthcare professionals? Their participation level. When we're having events and when they are having events, are we able to both participate seamlessly together as a team? Are our communities empowered? Do they hold us accountable? How is the health literacy in our communities? Do they know when they're supposed to be coming to the clinic? Do they know when they should be having a health beat or a health gathering? Their responsiveness to our interventions, our interactions, and our institutions, and also ensuring that we include our communities that are ordinarily marginalized in health decision making. So for me, that is what I believe we should be measuring to say that we are doing well. So it would be our communities feeling heard, feeling understood, feeling respected, feeling engaged, and seeing that as part of health systems strengthening.
Yeah. So we are almost towards the end of the questions. I just wanted to quickly check if any of our audience had any questions. If any of the, if anyone who has joined with us have any questions for Dr. Thokwane, I'll just give you a few seconds to ask her. You can directly ask her or you can type in the chat box. So while we see if we get any questions, I'll, move on to the next question that I wanted to ask you. What would be your top 3 recommendations to national and global leaders towards attaining health equity?
One of my favorite saying is that as health, we're at the tail end of everything else. We are not the drivers of health as the health sector. The drivers of health are actually outside the health sector. It's education, it's gender affairs, it's water, it's energy, it's minerals. So for us to actually reach our objectives or our end goal as health, it means that we need to do an all hands on board or an all sector on board approach or a whole of society approach to healthcare. So even when looking at health equity, it is not just about health, it's about the roads, because that's access. So health equity is not about health, it's about all of us. 2, we need to be investing in primary health care. It's the foundation of healthcare system, and we need to ensure that it's people-centered. It's for the people, by the people. And we need to have ensured that we've educated them, we have empowered them, such that they're able to set their own priorities. We have things that are working for them. Thirdly, a lot of the times we say we are inclusive when we are not. Yes. We are very performative, if I can use that word. So we need to stop being performative. And when we say we're actually engaging our communities, we are co-creating with our communities, we are allowing our communities to be leading the way, we should be doing that. And we should be ensuring that women have voices, young people have voices, and grassroots organizations have voices that are actually leading our healthcare system. So our healthcare, basically, especially because we are saying it's for the communities, we cannot do it when we leave the communities behind. So the communities should be leading it.
Thank you. So we have received a question from Sharon. Sharon is a very talented change maker, and she's part of the Global Activist Network family. Sharon asked you, how do we rebuild trust in healthcare systems within communities that have been historically neglected?
I think it comes back to the conversation that we had earlier, as in how do we build trust? Because it's about building trust. It's about ensuring that those communities understand and feel like they have power. It's about engaging them in their own right. I gave an example of using someone who's already in the community to help us open that pathway into having those conversations, and also listening to understand, listening to appreciate, listening to learn. And I believe that being in consistent or constant conversation, constant engagement with those communities will go a long way in building that trust. I said earlier that we usually remember our communities when we're in the middle of a crisis, when we're being responsive. But if we are starting or walking the path with them, starting from the beginning with them, it will go a long way in them building the trust with us. So whatever it is that we are thinking, let's engage them, and engaging them not in the way of ticking boxes, but actually going to them and saying, this is the issue. How do we think we can deal with this issue? How do we think, in your lived experience, this can work for the healthcare system? What are the solutions?
Absolutely. We need to be people-centered. We need to be community-driven.
Exactly.
Dr. Thokwane, health equity is a massive discussion. We are at the, end of our questions. I have my last question for you. And I feel that every question that I asked you requires a separate discussion, and you can keep adding to those areas. So we need to have you, we need to invite you again to have more very relevant discussions on health. But I'm just conscious of time. I'm going to ask you the very last question. What are your final words for us? And if anyone wanted to reach out to you, I don't know, for mentorship or wanted to discuss something or anything, how do we reach you?
All right. I'll start with my final words. So, like I said, for me, health equity is more than just closing the gap. It's about the quality of services that we give to our people. It's the love that we give to our people, because we should be driven by love for our people. It's not about management. It's about leadership. It's about co-creation. It's about ownership from our communities. It's about justice. It's about dignity. It's about solidarity. If we are doing this together, and it's an all hands on deck approach, I believe there's absolutely nothing that we cannot achieve. We need to stop the hero mentality. Our communities are not waiting to be saved. They're already innovating. They're already organizing. They are leaders in their own right. And our responsibilities are to create environments where they're able to thrive. So the future of health is actually in us working together. It's not just about financing. It's not about just technology. It's about whether people feel seen, they feel heard, they feel valued. And we need to ensure that we empower our communities and we give them that space to show that power and to lead themselves. So those are my final words. And I'm on LinkedIn. My first name and my surname, Karabo Thokwane. So anyone who wants to reach out to me, I'm on LinkedIn.
Thank you so much. I mean, we're really privileged to have you here and have this discussion. For people who don't know, we went live on YouTube, but we're going to post the whole session for many of our supporters. Apologies for the background noise. Many of our supporters, many of our change makers are located in different time zones. So they will come back at a later time to watch our session, but it will be on our YouTube channel, which reminds me we're on every single social media platform as possible. We're on LinkedIn, Facebook, Instagram, Twitter, X, Spotify. So please do support us. Please do join. Please do amplify our work, our voices, our change makers, because we are trying to bring grassroots voices to the global platform. If you see someone doing amazing work, please do nominate, because we spotlight change makers. If you're working on something great, or if you identify a challenge, write an article for us. We do publish articles that are related to the Sustainable Development Goals. And I would encourage everyone to research Dr. Thokwane's work, her milestones, so that more, young people pursuing health as a career can learn from many things that Dr. Thokwane has achieved, as well as our platform, what we're doing and what we're trying to achieve. So thank you everyone who joined, and a special thanks to Dr. Thokwane for making time on a weekend. And sharing your very valuable insights. Thank you so much to you and to everyone who joined today. And with that, I end today's session.
Thank you, Lems.
Thank you. Have a nice day, everyone.